Hello and welcome to our session today. Today we are looking at fluids and electrolyte imbalance. This is one of the key topics in our fundamentals of nursing and critical care nursing, and it cuts across all the units that you'll be pursuing as far as basic nursing sciences are concerned. So we can start by looking at the objective. So the first objective, you should be able to define the fluid and electrolyte imbalance. You should be able to identify electrolytes and also state the roles they play in maintaining the physiological balance. Number two, you should be able to, by the end of this session, you should be able to recognize common signs and symptoms of fluid volume deficits and excesses associated with these fluid and electrolyte imbalances, like the hypernatremia, hyponatremia, hyperphosphatemia, hypercalcemia. We are going to look at them. Next, by the end of this session, you need to be able to perform a basic fluid and electrolyte assessment using standard tools. They could include intake and output measurements, the daily weights. Besides, you should also be able to utilize the basic laboratory values to assess fluid and electrolyte status. Lastly, you should be able to implement a basic nursing interventions that is geared towards correcting and managing fluid and electrolyte imbalances. So, in addition, you just need to be able to administer oral and intravenous fluid as appropriate. So, the world of fluid and electrolyte imbalance. The fluid, these are just substances that can flow and to have do not have fixed shape, and they found in the human body, and they have a number of roles to play, starting with it being used as a medium of transport for different substances. They're also needed for different cellular metabolism and also act as a solvent for different electrolytes and other constituents in the body. Besides, fluids will also be involved in regulation of body temperature along with digestion, elimination, and also being used as a lubricant, especially like the joints. You'll have the synovial fluid that is going to be acting as a lubricant, reducing friction between the articulating bonds. Besides, we also have amniotic fluid that's also very significant and act as a shock absorber, and that is very significant for the different fluids. Distribution of the total body water. If you try to look at the total body and you try to compare it, what is the solid part and what is the fluid part, you find that 55 to 60% of body weight will be made of water, and this is normally influenced by a number of factors. It could be age, gender, or body fat. So as for the age, you find that younger people will have a higher percentage of body fluid compared to the adults. This is equally true for the infants. They have a higher percentage of body weight as water. Now, for the elderly, they tend to lose muscle mass, okay, and as they age. So when they lose this one, they normally decrease the percentage of body water. Remember, the muscle mass is the one that is able and responsible to hold more water. So the more muscle mass you have, the more water you have. So that means men, because they have more muscle mass, they normally have more water than the females. And this can also be shown in the terms of body composition. 55% of females will be water, while 60 of the total body weight of males will be water. You can see that difference of about 5% or so. In terms of gender, men have proportionally more body fluid than women. I think we have already said because they have more muscle mass. And if you compare it in terms of body composition, especially the body fat, you find that obese people have less fluid than the thin people. So fat cells normally contain very little water. Okay, so it could be 60% for the males or 55% for the females. But all these fluids is they normally found in different fluid compartments. And we have two major fluid compartments. The fluids could either be in the intracellular space or the extracellular space. So, based on the different gender, maybe 55 or 60, you find that out of that percentage, almost 60% will be water ice. So, intracellular space is majorly found inside the cells, and that's within cell membrane, and it contains a number of compositions like water, electrolyte, ions, proteins, and other solutes. It supports the structure, metabolism, and the various cellular processes. Extracellular fluid, on the other hand, this one consists of 2%, one third of that percent. So, regardless of the gender, it could be 55 maybe for the females. You find that 60 out of that 55 will be found in intracellular space, or 60% for the males. So you find 60 out of 100 of this 60 will be found in intracellular space. Now, and that is equivalent to almost two-thirds. Okay, so the other third, about 40%, is the one that will be found now in the extracellular fluid, and this is outside the cell. So outside the cell, and it could mean the interstitial fluid, it could mean the plasma or the transcellular fluid. This one, extracellular fluid, will contain water, electrolytes, proteins, and other solutes, almost just the same as the intracellular space. And extracellular space facilitates nutrient and waste exchange between cells and their surrounding environment. All right, I can be able to appreciate that two-thirds of the fluids will be found in the intracellular space, and a third will be found in the extracellular space. Out of this, a third, 80% of it in the interstitial and 20% in the plasma. We can try to get the different categories of the extracellular space. In this case, we could have the interstitial fluid. This makes up around 15%, and it's the space that is normally found between cells and tissues. This is the fluid that will provide a medium for exchange for the nutrients. This could be oxygen, including waste products between the cells and the blood vessels. The second category under the extracellular space is the plasma, and this one constitutes the liquid portion of blood, and the percentage is about 4 to 5%, and it does contain water, electrolytes, proteins such as the albumin and the globules. Remember, albumin is the one that is going to maintain the oncotic pressure. All right. We also have hormones, other solids, and this plasma, it normally plays a role in transporting nutrients, especially the hormones waste throughout the body. Lastly, we have the transcellular fluid, and from the word transcellular, it refers to these specialized fluids contained within some body cavities. Or we could have cerebrospinal fluid, the synovial fluid, or the digestive juices. In terms of percentage, it's estimated to be around 1 to 2%. So, ladies and gentlemen, you have to ask yourself, how is water regulated in our body? Because this is the major player that you are trying to look at it. In terms of organs, you find that the kidneys are normally the primary organs responsible for regulating the water balance. So, the kidneys do filter blood to remove the waste products and excess waste, which water is one of the component. So the amount of water reabsorbed by the kidneys adjust based on the body's needs. So hormones like the ADH and aldosterone will be playing a role in reabsorbing the water into the kidneys. If we start by looking at the ADH, the antidiuretic hormone, okay, antidiuretic, so it's against loss of water. And this one is normally produced by the hypothalamus and then released by the posterior pituitary gland. So ADH, what it does, it increases water reabsorption in the ascending loop. All right. So when there is low water intake or an increase in blood osmolarity, the ADH will be released to conserve more water and concentrate the urine. Aldosterone, on the other hand, is produced by the adrenal cortex. Okay, adrenal cortex, specifically the zona glomerulosa. So, the aldosterone in this case will regulate the balance of sodium and potassium in the body, and it promotes sodium reabsorption in the kidneys, leading to water retention. Remember, wherever sodium goes, water will follow. So, if you reabsorb sodium, it means you're going to retain more water. The other factor that really plays a role in this fluid balance issue is the thirst mechanism. And this is a sensation that is a very powerful regulatory mechanism that will promote or prompt individuals to drink water when their bodies are dehydrated. So the thirst response is normally triggered by a number of factors. It could be an increase in blood osmolarity or a decrease in blood volume. Remember, the thirst mechanism is significantly reduced in the elderly population, and that's why they are normally at risk of also suffering from dehydration. So you have to keep on reminding the elderly that they have to take kind of some fluids for them to maintain the normal homeostasis of the body. The other one is the skin and the lungs. So water, it's good to know that the water is normally lost through the skin in the form of sweat and through the lungs during respiration. So the regulation of body temperature through sweating is an important mechanism for cooling of the body. However, if it is excessive it could result or lead to also contribute to dehydration. Lastly, you have the digestive system, and in digestive system, we normally have a small amount of water that is absorbed in the digestive tract, and this is majorly the colon. Okay, this part is not so significant compared to the others. Remember, the kidneys are the primary organs responsible for regulating water balance. So in fluid imbalance, we could either have deficient, deficits, or excess. So if you look at deficit, okay, this will be involving losing water, okay, and electrolytes from the extracellular space. And this number result in two terms that we refer to as isotonic dehydration or hypertonic dehydration. So that in isotonic, we'll have water and electrolytes is lost in equal amounts. It could be through diarrhea or vomiting. While hypertonic dehydration is water is lost greater than the electrolytes, right? So more water is lost, and electrolytes could be left, and this is could be through excessive aspiration or diabetes insipidus. So, what the causes could be like you have a failure to take or absorb water by the kidney, okay, or inappropriate ADH secretion. So, if more ADH is being produced or less, okay, less, more, okay, more is being produced, then that means what? Okay, less being produced, it means less water will be lost. Okay, more being produced, it means more will be retained. Could also have loss of fluid from the GIT, could be through diarrhea, vomiting, or the suctioning or the GIT fistula. Excessive sweating, prolonged fever, and also impaired integrity could also lead to fluid loss. Or could also have a hemorrhage or ovaries of diuretics. All these could lead to a fluid volume deficit. Equally, for the fluid volume of course we normally have we could also have a fluid shift out of the vascular space into the interstitial space, what we normally refer to as third spacing. So when tissue injury occurs, proteins pathologically will leak from the intravascular space into the interstitial space, and you know this proteins, especially the albumin, is the one that normally exerts the glycotic pressure and is able to attract the water molecules, and they are within the blood vessel. If that's lost, then it means they will be drawn in the interstitial space where they will draw water, and conditions such as edema would result. So we could have, in terms of signs and symptoms, you could, because of fluid deficit, you could have diminished peripheral pulses, hypertension, increased heart rate just to compensate, and hematocrit, slow capillary refill as is less than 3, of course. That could be now more than 3 seconds. Tachycardia, ocular task, decreased motility, diminished bowel sounds, constipation, decreased urine output, increased urine specific gravity, and weight loss and hypernatremia. We could also have decreased CNS activity, fever, skeletal muscle weakness, hyperactivity, deep venous tendon reflex, fatigue, dry mouth and skin, poor tag, sitting, edema, and sunken eyes. Remember, if you want to elicit skin tagger in the elderly, you have to look at the bony prominence areas, because that is the place where we might not be having the unnecessary wrinkles that might confuse you as you do your own assessment. In terms of intervention, you can prevent further fluid loss, okay? And we could also have the intravenous and oral rehydration therapy. Could have this medication, the antidiarrheal drugs, because you know most of the fluids will be lost through dehydration. So if you can block that, we could also conserve some fluids. We could also monitor the cardiovascular system, respiratory, renal, GIT, and monitor electrolyte supplements. Also monitor weight and fluid status, input and output. What about the volume, fluid volume excess? In fluid volume excess, actually we have a fluid overload. It's excess body fluid. And we could have things like hypervolemia. This is excess fluid in the intravascular compartment. So we have edema. So we have excess fluid in the interstitial spaces, right? And the causes of this fluid volume excess could be intake being more than the output. Remember, at least we encourage for all the most patients that the input should be around 3 liters per day. Hypotonic fluid overload or increased sodium and water retention, a syndrome of inappropriate ADH. So syndrome of inappropriate ADH, it means now we are going to lose less fluid. So we're going to have excess. Other conditions like renal failure, it means the renal, of course, is the one responsible for removing this waste, including water. So if it has failed, it means water is going to accumulate and therefore result in fluid excess. Same to the congestive heart failure, especially the right-sided heart failure that leads to conditions like ascites and other fluid accumulation due to impaired venous return. In that case, you're going to have fluid excess. So patients are going to present with elevated pulse, BP, distended veins, and hand veins, hyponatremia, edema, reduced hematocrit, serum electrolytes, abdominal cramps, and nausea and vomiting, weight gain, and altered mental status. Patient could also present with dyspnea, difficulty in breathing, and pulmonary edema, so fluid accumulation in the lungs, and periorbital edema could be pitting or non-pitting due to fluid accumulation. So what you're supposed to do as a nurse, you have to aim to restore the normal fluid balance and preventing further overload. Drug therapy, diuretics could be of help just to remove excess fluid, and diet therapy, you have now to decrease sodium and fluid in that case. You also monitor the input output and monitor weights so that we are able to see how weight is fluctuating as you continue to manage your patient. Also monitor the electrolytes and the other systems that have been involved just to ensure that everything is okay. So this concept of the third spacing, where we are moving, of course, we have already mentioned the intracellular space and the extracellular space. So in third space, spacing, this moving too much fluid from intravascular space to now the interstitial or the non-functional areas. Remember when you're looking at the different compartments, we say that the intracellular is going to be getting the large portion of the fluids. So when you have a shift for the fluids, this is going to result in what we call third spacing. So it will occur when fluid accumulates in these areas that normally have no fluid or minimal amount of fluid, and is caused by an increase in filtration or decrease in reabsorption due to altered capillary forces. Signs and symptoms could include now decrease in urinary output despite adequate fluid intake. So it means the fluid is not coming out, it's going in another compartment which needs to be investigated. Patient could also present with increased heart rate, decreased blood pressure, and decreased central venous pressure and edema. So they will also have increased body weight and imbalances of fluid and in fluid intake and output. So the major causes could majorly be we could having massive inflammation or venous obstruction or increased blood flow or just low serum albumin that could be resulting in such causes. So fluid and electrolytes are affected by different factors, and it is of help for you to know this. Of course, we have already introduced about the trauma. Yeah, somebody was just sustained a traumatic injury, blood loss, the burns, diarrhea, or NG tube infection is likely to lose the fluids, causing imbalance. And conditions such as aldosteronism and ADH pathologies could also interfere with this state. Remember, when we were looking at regulation of water, we mentioned what ADH does and what aldosterone does. So if we have any pathology in this, automatically it's going to affect the fluid balance. So we have several electrolytes in our body, and we can just look at the most common one as because this is what is commonly tested, and that means that is the most important. However, we can also get some time and look at the others at some time. But let's start with sodium. This is mostly found in the extracellular space, and it's very important. So it will be more on the outside than the inside because it has to facilitate the process of depolarization. So it does regulate also water in and out of the cell. We say wherever sodium is, almost water will be following it. The normal range for sodium is about 135 to 145 milliequivalents per liter, and is very important for muscle contraction and nerve impulse condition. Causes of hyponatremia. This is reduced amount of no sodium. Okay. Maybe you could have excess fluid. If you take excess fluid intake without a corresponding increase in sodium intake, it can lead to dilution of the sodium concentration in blood. So this leads to hyponatremia. Also, kidney function. Remember, in the chronic kidney disease, it can result into inability to excrete water. So, if you are not excreting water, it means it's going to accumulate and dilute the sodium that's there, resulting into hyponatremia. What about heart failure? Of course, we know from our physiology class that the heart is the one that is responsible to pump blood. So in heart failure, the heart may not be able to pump blood effectively, and this causes blood to back up in the veins. So what does this happen? This leads to fluid retention. And fluid retention, when you have more fluids, is going to also contribute to dilation of the sodium in blood, leading to hyponatremia. Liver cirrhosis can lead to a decrease in production of proteins. Remember the one that when you are measuring the albumin, the one that's responsible for maintaining the oncotic pressure or keeping those liquid in the vessels. So you find that this can maintain. So this is responsible for maintaining blood volume retention. So if retention whatever is there, then hyponatremia is going to result. Also, the CIDH, this is syndrome of inappropriate ADH. This is a condition characterized by excess ADH. You know, ADH is against loss of water. So when you have excess ADH, it means you are going to lose very little or no water. So when you have more water, it means you are going to have more water retention, which is able now to dilute the sodium in the blood, resulting into low level of sodium in blood. Also have adrenal insufficiency. This is a condition that we normally refer to as Addison's disease. And the Addison disease here, you find that the adrenal gland will produce hormones that are very minimal. Okay, the aldosterone. Of course, we already know the aldosterone is it normally regulates the sodium and water balance. So when you have adrenal insufficiency, it means it's going to result into aldosterone production, which leads to hyponatremia. Also have certain drugs, especially the diuretics, the antidepressants, and certain antiepileptic drugs can also increase the risk of hyponatremia by affecting the fluid balance. We also have severe vomiting or diarrhea, hormonal changes that normally occur, such as the hypothyroidism, could also contribute to hyponatremia. And we have some signs and symptoms of hyponatremia. We normally use the mnemonic salt loss. So somebody could see the stupor, coma, anorexia, lethargy, tendon reflexes decreased, limb muscles weakness, orthostatic hypotension, the seizures or headache, and the stomach cramping. So we are going to have the cramping and the weakness, and the rest. The patient will be restless, and will have altered mental status that can be ascertained by maybe observing the patient is confused or suffering from delirium. Also, the neurological symptoms like the seizures, the headache, right? That could also be in this case for that kind of patient. So that is all about the hyponatremia. So now let's look at hypernatremia. This is increased sodium level. Remember, the normal range you have already indicated is between 135 to 145. So this is exactly the more than 145 milliequivalents per liter. So, and this could be caused by inadequate fluid intake. Okay, you're not taking in enough fluids, so this leads to dehydration and a higher concentration of sodium in blood. You could also be having excessive fluid loss, where you could be suffering from conditions that are contributing to such. Maybe you have lost fluid through prolonged vomiting, diarrhea, or excessive sweating, or the use of diuretics, which can also result in hypernatremia. Diabetes insipidus, this is a condition that is characterized by inability of the kidneys to concentrate urine. So this leads to excessive urination and dehydration. Okay, as a result, you suffer from hypernatremia. What about hyperaldosteronism? This is normally characterized by overproduction of aldosterone, and aldosterone is the one that is responsible to regulate sodium and potassium balance, and this can lead to increased sodium retention, contributing to also hypernatremia. In Cushing's syndrome, this disorder is characterized by increased level of cortisol that can increase sodium reabsorption in the kidney and also contributing to hypernatremia. What about hypertonic saline solution? Well, administration of hypertonic saline solution, as often used in medical treatment, can also lead to excess sodium in blood if not properly monitored. Then you have also excessive intake of sodium, where you have gone beyond the recommended levels. And lastly, the elderly population are at increased risk due to decreased thirst perception or difficult in accessing the fluids. Thus, they suffer from hypernatremia. So, to remember the signs and symptoms of hypernatremia, we use the mnemonic. All right, we have the fried salted, and we have the Higgs hash. Okay, the high salt. So high salt, high stands for H stands for hypothermia. This is elevated body temperature. So patients will be presenting with elevated body temperature. So, and that explains why patients with elevated body temperature normally put on fluids. All right. Also have increased thirst. We have greatly decreased urine output. Remember, the recommended urine output for a patient is about 30 mL per hour. Then we have the hyperrexia. These are overreactive or heightened reflexes. And then you have skin flushed. It could be dry, flushed skin, or a patient presenting the agitation. They are restless, so there is low fluid intake, and this is normally related to increased thirst. And then thirsty, constant feeling of being thirsty. That was some of the signs and symptoms associated with hypernatremia. The second one, electrolyte we're looking at, is the chloride ions. And the chloride ions, guys, the normal range is between 95 to 105 milliequivalents per liter. And chlorides are normally excreted in sweat, GI juices, and this is majorly controlled by the kidney. Chlorides are the second most abundant ion in the body, and is the major anion in the extracellular space. It normally combines and follows sodium. So we have sodium chloride. So higher levels will be found in the cerebrospinal fluid, the bile, the gastric, the pancreatic juices. Chloride ions do play a role in maintaining the body's natural pH, aiding in digestion, especially when it's combined with the hydrogen. So you have hydrogen chloride in the GI, in the gastric mucosa. And then you have the maintaining the osmotic pressure of the body. Chloride are associated mainly with sodium, and they are inversely related to hydrogen carbonate. So when you have low chloride ions in the body, less than 95, some say 96, we refer to that condition as hypochloremia. So it normally results from prolonged vomiting and suctioning. And we have hypochloremic alkalosis, right? So we have the loss of the chloride, right? So in this case, we have the metabolic alkalosis, nerve excitability, muscle cramp, twitching, hyperventilation, coma, arrhythmia, slow, shallow respirations, hypertonicity, hyperreactive reflex, and tetany. And the treatment here could just be looking at the diet, find the diet, and IV therapy for that case. The major causes of hypochloremia could be loss of fluids, of course, loss of fluids, or diuretic use, hyponatremia, metabolic alkalosis for that case in this one. In addition, we could also have COPD condition, which normally leads to retention of the carbon dioxide and respiratory acidosis, in this case, which is associated with hypochloremia. Addison disease, the adrenal, of course, is not able to produce enough hormones, including the aldosterone, and the aldosterone is the one responsible for regulating chloride levels, and its deficiency could lead to hypochloremia. Then you have the Bartter syndrome. This is a rare genetic disorder that normally affects the kidneys, leading to electrolyte imbalance, including the hypochloremia. Certain drugs, such as the laxative corticosteroids, may contribute to electrolyte imbalance, including this hypochloremia, the one that I have just mentioned. So patients with hypochloremia will be weak and fatigued. The dehydration will also result in it, and somebody will suffer from hypertension, metabolic acidosis, alkalosis, muscle cramp, nausea, vomiting. Although edema is very rare, it's common with hypochloremia and may contribute to imbalances leading to swelling or the edema. Then you have the arrhythmias, where severe imbalances, including hypochloremia, may also affect the heart's activity, potentially leading to arrhythmias. So from those low levels, we can look at now the high levels. So the excess levels of the chloride will lead to chloremia. Okay, it is caused by excessive intake or retention by the kidneys. Increased intake, the drugs like ammonium chloride, calcium, and carbonic anhydrase inhibitors like the acetalamide and the they can contribute to this process of hypercholoremia. All right. So others could have hyperparathyroidism, intravenous fluids, gastric acid loss, the hypertension, carbonic anhydrase. We have already mentioned lactic acidosis, overhydration, and controlled diabetes and diuretic. We can use the mnemonic high cloud to get all the causes of hypercholoremia. So to get the symptoms, we use the mnemonic clouds, where C stands for confusion. Patient could present with lethargy, overhydration, where due to fluid retention and unexplained weakness and fatigue, decreased cognitive function, and slow and shallow breathing. We can just treat by restoring the fluid and the electrolyte balance. Next, we have the potassium. I know, guys, you're expecting me to start with this one. I don't know for your case, but we have just looked at the first two major, and then we can now go on with potassium. Potassium is very important in the body, along with sodium, chloride, and magnesium. And now its major role is to maintain the right balance of these electrolytes, which is critical for nerve impulses, muscle contraction, and fluid imbalance. Potassium does play a vital role in resting membrane potential of cells, including nerve cells and muscle cells. So this is essential for the transmission of nerve impulses and contraction of muscles. It's also very important in regulating electrical activity in the heart, and this contributes to maintaining of a regular heartbeat. So both too much and too low could lead to cardiac arrhythmias. For the kidney function, we find that also the kidney plays a significant role in regulating potassium levels in the body, so they can adjust excretion or reabsorption of potassium based on the needs. For the dietary resources, this one is normally obtained majorly from good dietary resources such as the fruits, could have the bananas, the oranges, the melons, or vegetables such as potatoes. We could also have spinach. We also have tomatoes, dairy products, meat, and nuts. So abnormal levels of potassium can lead to health issues. It could be hypocalcemia or hypercalcemia. So if you look at hypocalcemia, patient is going to present with cuts, that is constipation, arrhythmias, it could be regular heartbeats, tetany, muscle spasms or cramps, and the skeletal muscle weakness or the cramps. As for the hypercalcemia, the patient is going to present with machine. So this is muscle weakness, arrhythmias, cardiac arrest, hyperreflexia, that's overreactive or twitching reflexes, intestinal cramping or diarrhea, numbness or tingling sensation, and ECG changes. These are majorly the peaked T waves. All right. Next, we have the calcium. So calcium, the normal range is between 8.5 to 10.5 milligrams per deciliter and is most abundant in the body. 99% of calcium is found in teeth and bones. Okay, so we have equal concentrations in the ICF and the ECF. And calcium has an inverse relationship with phosphorus. So enzyme activator within cells, muscle contraction also helps in regulation, cell membrane permeability and firing, and is also needed for nerve transmission and vitamin B12 absorption. So you can see calcium is equally important in our body. So we have to maintain the calcium balance in our bodies, and we have around two hormones that are very important for that. We have the parathyroid hormone PTH and the calcitonin hormone. So parathyroid hormone is normally produced by the parathyroid glands, and it does stimulate the release of calcium from bones by activating the osteoclasts, and therefore increases reabsorption of calcium in the kidneys and activates production of active vitamin D in the kidneys, which enhances intestinal absorption of calcium. In short, PTH normally increases the level of calcium in blood. As for the calcitonin, this is normally produced by the C cells of the thyroid gland. It inhibits the activity of the osteoclasts, so that means it leads to decreased release of calcium from bones. Also promotes excretion of calcium by the kidneys, so it reduces the level of calcium in blood. So in all this, you have to know the osteoblasts, which are the bone forming and very important in calcification or mineralization, for that case, and osteoclasts, which are bone resorptive cells, and they normally break down the bones tissue so as to release the calcium. Okay, so these osteoclasts are related to the PTH, whereas osteoblasts are related to calcitonin. So we have signs. We could start with hypocalcemia, where where you have reduced levels of the calcium. Okay, and this could be caused by low intake or loop diuretics or alcoholism. Furthermore, we could have parathyroid disorders, renal failure, magnesium or vitamin D deficiency, elevated phosphorus, GI losses, and decreased albumin. Also, the patient is going to present with gut cell. So, we could have convulsion, arrhythmias, tetany, spasms, and laryngospasms. So, one of the defining signs that all of us as nurses we need to know is what we refer to as the trochea and the Chevreck sign. So for the Chevreck sign is a clinical involuntary twitching of the facial muscles in response to tapping over the facial nerve for that case. So it is an indicative that there is hypocalcemia, and it's often observed by just tapping the facial nerve just in front of the ear, okay, in front of the ear here, okay, and this could lead to increased excitability of the nerves, the facial nerve in particular, and may become hyper excitable, okay, causing facial muscle twitching. As for the trochlear sign, this is of course another sign of hypocalcemia, but it involves induction of the carpopedal spasms. That is the flexion of the wrist and metacarpal joints with an extension of the interphalangeal joints when the BP curve is inflated above your systolic pressure for like 2 to 3 minutes. So hypocalcemia could cause this increased neural excitability leading to spasms, and this is what is being demonstrated in this case. So the others could have the laryngeal stridor and the Ebbs and the Ebb sign for that case. So what about signs and symptoms of hypercalcemia? So we normally use the mnemonic, the GROCH. So the patient may have the gastrointestinal issues. Patient suffers from constipation, nausea, and vomiting. We also have renal or the kidney stones for hypercalcemia. Also, osteoporosis, muscle weaknesses, cardiac arrhythmias, confusion, lethargy, and elevated BP could be one of the signs and symptoms of the hypercalcemia. So that gives us another chance to look at another electrolyte, and in this case we are looking at phosphorus, and the normal ranges is between 2.5 to 4.5 milligrams per deciliter. Phosphorus is needed for maintaining the acid-base balance, neurological and muscle functioning, and helps in energy transfer, the ATP. So it affects metabolism of the carbs, the proteins, the lipids, and also the B vitamin synthesis. It's majorly found in the bones and is regulated by intake by the kidneys. It's inversely proportional to calcium ions, and it's a major ICF intracellular space, an ion. It promotes energy storage and metabolism of the carbohydrates that we have already mentioned, and it's a buffer to the hydrogen ion. So it also transports oxygen and also maintains the integrity of the white and platelet function. So when it has some influence with the PTH, when we find that decreased phosphate concentration while increasing the calcium concentration. Whereas influence of calcitonin, this one will increase calcium phosphates while decreasing calcium concentration. Remember, PTH and calcitonin will be regulating also the calcium in the body. So the PTH increases the level of calcium in the body but decreases the level of phosphate. Whereas calcitonin decreases the level of calcium in the body but increases the level of phosphorus in the body. So we could have hypophosphatemia, and it could just because of the shifting of the fluids, and a patient is going to present confusion, coma, chest pain, bleeding, excitability, or osteomalacia, and renal electrolyte wasting. So we just treat and use the IV therapy. Whereas the hyperphosphatemia, these patients have a serum level of greater than 2.6 milli equivalents per liter, and it could result from renal failure or low intake of calcium. Remember, it's secreted by the kidney. So if phosphorus, the kidney fails to secrete, then you're going to have hyperphosphatemia. The body can also tolerate hyperphosphatemia fairly, but with the accompanying hypocalcemia, it could be a larger problem. So problems will be resulting from the hypocalcemia. So renal insufficiency, increased intake, and the shifting. In this case, the cell destruction by the chemotherapeutic. The breakdown of the muscles and the decreased renal loss, okay, could cause hyperphosphatemia. So we could have calcification where we have calcium phosphate precipitated in soft tissues, joints, and arteries. Patient could present with olguria, corneal haziness, and conjunctivitis, along with irregular heart rate, dysrhythmias, and papillar eruption. So in this case, you have to decrease the phosphorus intake and absorption, and the fluids to flush out the phosphorus. Work on the diet to reduce the amount of phosphorus in the body, and they also have hypocalcemia intervention in this case because hyperphosphatemia will present along with hypocalcemia. So medication could include the phosphate binding so as to remove excessive phosphate, and if it goes the worst, then we have to do the dialysis for that case. The other mineral is about magnesium, and the normal range is 1.5 to 2.5 milliequivalents per liter, and is mostly located in the intracellular space. Magnesium is needed for activating enzymes, electrical activity, metabolism of the carbs, the proteins, DNA synthesis, and regulated by intestinal absorption and the kidney. So on regulation of magnesium, you find that parathyroid also increases the plasma magnesium concentration. Remember, PTH increases the calcium, okay, along with the magnesium, but decreases phosphate, okay, and this is by decreasing the amount of magnesium excreted by the kidneys. Whilst the anion, you find the chloride is indirectly increased by aldosterone because it passively follows sodium. So we could have hypomagnesia or hypermagnesia. For hypomagnesia, we're talking of a serum level of less than 1.5, and is very common in critically ill patients. It is associated with a high mortality rate, so increase in cardiac irritability and ventricular dysrhythmia, especially in patients with a recent myocardial infarction. So maintenance of adequate serum magnesium has shown to reduce mortality rates post the MIs. Causes of the hypomagnesia. result from decreased intake or absorption, and also have chronic alcoholism and nasogastric sanctioning, also have increased GI losses and hyperaldosteronism. So patient will present with confusion, increased neuromuscular excitability, seizures, cardiac dysfunction, especially increased QT and interval and ventricular arrhythmia. So in terms of treatment, you have to supplement the magnesium and we have the calcium gluconate, the one that you're going to treat for calcium, right? Because you know magnesium and calcium, they go hand in hand. So when the level of magnesium is down, of course the level of calcium is low, and no wonder we are giving calcium gluconate to boost the hypocalcemic state. So we have the magnesium, hypermagnesia. So this is a serum of greater than 2.5 milliequivalents and result from renal failure and increased intake. So the kidney has failed to secrete magnesia. So magnesium accumulates. So we could have symptoms like flushing, lethargy, cardiac changes, e.g. decreased heart rate, decreased respiration, and loss of deep tendon reflexes. So in this case, you just need to restrict fluid intake and do some diuretic treatment. Causes of hypomagnesia, it could be renal failure, so we have increased magnesium intake and retention, along with now the other could be acute adrenal cortical insufficiency, hypothermia, and increased magnesium sulfate administration. So the patient will present with decreased neuromuscular transmissions, decreased neuromuscular excitability, paralysis, decreased or absent reflexes with the rest. So we could have intervention like you stopping the intake, increasing fluids with diuretics, and dialysis if there is renal failure. So calcium gluconate will try to oppose calcium magnesium life-threatening effects for that case. So you could have different fluids for the different electrolyte imbalances. Like for the normal saline, the 0.9 normal saline is normally indicated for intravascular fluid replacement or rehydration, and the electrolyte under consideration here is sodium and chloride. Dosage could vary from 500 mils to several liters. Rigorous lactate is for the fluid replacement on metabolic acidosis, surgery, and trauma. Electrolyte considerations here could be the sodium, chloride, potassium, calcium, and the lactate. So the dosage is normally 20 mils per kg per hour. As for the albumin, it's for patients with hypovolemia, patient with burns, patient with liver disease. Remember, but they are not able to produce these proteins, the albumin, the globulins, or the nephrotic syndrome. So this one will vary in terms of dosage from 25 to 50 grams, but does not directly address electrolyte imbalance. Instead, the shifting of the fluids in the spaces. For the packed red blood cells, will be indicated for anemia, blood loss, hemorrhagic shock, and they are primarily focused on oxygen carrying capacity and volume. And this is normally, dosage is normally based on the weight until it contains, the 1 unit you find it contains around 250 to 300 mils. For the FFP, the fresh frozen plasma, is indicated for the reversal of coagulation factors deficiency, coagulopathy. So it contains clotting factors and protein for that case. So the dosage is about 10 to 20 mils per kg. Lastly, we have the mannitol, which is normally indicated for cerebral edema, osmotic diuretic, and intraocular pressure reduction. So this may cause initial increase in serum sodium levels, and it's good for us to know that. So the dosage will be varying between the 0.25 to 5 grams to 2 grams per minute. So guys, that wraps up the end of our presentation on electrolyte imbalances. Guys, you can access the free quizzes testing all the electrolyte imbalances affecting the different electrolytes, be it sodium chloride, phosphate, magnesiums, and the general presentation of the topic on fluid and electrolyte imbalance. So guys, you can have a check and look at them and just have the feeling of those different quizzes just to improve your understanding and to cement your knowledge on this topic. Until we meet next time, goodbye.